The reason I like process improvement from a process improvement model is that it doesn't ask you to give the answer. It asks you to build understanding, to identify the problem, figure out what the moving parts of that problem are. In endoscopy, we were doing things that didn't necessarily need to be done. How about we try it a different way? There's no feelings, there's no we did it right. It's just, this is your system. This is your work. If we tweak it a little, the patient gets a better experience and you do less work as the care provider because you're doing the right work at the right time rather than working really hard to catch up for doing the right work at the wrong time. My name's Ralph. I am the patient care manager for endoscopy in the Edmonton zone. So the first time when we started to utilize Alberta Improvement Ways, so AIW without AHS, was when we created a new larger center at one of the larger tertiary sites. I was the unit manager at the time. Before we were 5 small rooms and we moved up to a 10 theater, 28 bed prep and recovery center, which was much larger. We knew this was going to be a massive change, so me, another unit manager from another larger hospital, the patient care manager, several of the leads for an endoscopy lead nurse and a prep and recovery lead nurse. We actually formally went into, at the time, Alberta Improvement Way, and then we were supposed to use that knowledge to develop a project. What actually happened was the team who was training us realized how large the project was and actually offered their services.
So I'm Chetan, I'm with the Process Improvement Group. I'm currently the improvement lead for provincial initiatives. But when the endoscopy unit was being started up, the new endoscopy unit, I was then the senior consultant with the Process Improvement Group. We were doing very similar kind of projects elsewhere, but we've never done a project with the endoscopy unit itself, anywhere in the province.
So after we gained some efficiencies in moving up to our new unit, what we realized was there was lots of opportunity wasted within the endoscopy theaters. And the reason that was there was staff available, theaters available, but no physician available.
So what we decided to do was to have the conversation with the physician, show them the extent to which theater time was being lost, and come up with consensus on what it would be or what it would take for us to get them to release a portion of those slots and to ensure that no slot was lost when physicians were either on call, they were on vacation, they were on conference.
The physicians realized that we were using probably in the 70%. So what that means for you and I is that's almost 40, 30-minute slots per week that were left available for physicians who wanted to provide care to their patients, but no means by accessing it. So even though we had a system that gave the availability of the docs to the time, it just wasn't working. And that's no fault to any individual. It's the system needs to be engineered differently. So the divisional director at the time, the physician lead, we came up with a project which was more of a huddle based. The huddle project specifically was the active involvement of the people doing the work. They literally huddled around a table, looking at the release schedule for the next 6 months on paper, saying, I'll take that, and the next doctor saying, I'll take that, and I'll take that. So what we saw the doctors actually do was, through a very active means, on a regular basis after that, go in, choose a day where they all know this is what's going to happen, meet around the table, and take all the available time for the next 6 months of endoscopy to make sure they're utilizing the service they have available to them. And the successes rolled in quite quickly, very fast. Within the first huddle, they were in the high 80%. So we just used instantaneously another 10% of those slots, 10 slots per week. Then within the next huddle, we were in the high mid-90s. So we know that after one phase of 6 months, we used another chunk of those 30-minute lost in slots. And then within the next phase of 6 months, right away we were down to less than 10 slots per week loss in a large unit that puts through more than 70 patients a day. I think the biggest part we use for the sustained results is we actually spread it. We took the model, we went to another group of physicians at another facility that has similar issues for efficiency. We said, give it a shot. And what's funny is the spread, the efficiency of the first round of the spread was nearly 100%. They are now on to their second rollout at the second facility, and we're on to our third or fourth rollout at the original facility. So the model works for larger centers that has multiple theaters and multiple care providers.
So I think the biggest satisfaction for me in this role is to see that the changes that we bring forth drive better patient outcomes. It's more meaningful for me than anything that I've done before when I see that the patients directly benefit out of the changes that we bring about. So the patients are benefiting in terms of how soon they get to see their doctor, the outcomes that they experience on account of it. But at the same time, we're not compromising by making the staff work harder. We're getting a win for them as well. So it's a win for the patient, it's a win for the staff, it's a win for the management. So to be able to bring together a triple win in a situation like this is something that gives me a great sense of accomplishment and pleasure to be here every day.
What matters is the efficiencies you gain in your system, the quality of the standard work, making sure everyone understands their role in providing the patient experience. The patient always benefits.